Hello everybody, and welcome to this interview session for the European Stroke Organisation conference. I'm Terry Quinn and I'm a researcher from Glasgow in the UK, and I'm incredibly pleased to be speaking with Jessica Gong on the research that she's presenting at the conference today. So Jess, do you want to just introduce yourself and tell people the title of your paper?
Great, thank you, Terry. My name is Jessica Gong, and I'm a final year PhD candidate at the George Institute for Global Health in Sydney, Australia. The project I'm presenting at ESOC this year is titled Predictors of Cognitive Decline and Dementia in People with Prior Stroke or Transient Ischemic Attack, with results from the PROGRESS trial.
Brilliant, thank you. So, a paper on cognitive decline and dementia, one of my research interests. Previously, stroke conferences didn't have a lot of material on cognitive decline dementia, but this year ESOC has lots and lots of sessions. Why do you think this is such an important area to work in?
Yeah, so there have been many medical breakthroughs in stroke treatments that have significantly increased stroke survival rate. So while this means a reduction in stroke mortality, we cannot ignore the other side of the picture, and that is the increasing burden of morbidity associated with stroke. So post-stroke cognitive sequelae are becoming major concerns among stroke survivors. Around 1/3 of the stroke survivors develop cognitive decline or dementia. So post-stroke cognitive decline and dementia can be debilitating for these individuals. This also imposes substantial burdens for the stroke survivors, their families, carers, and also societies at large. Further, there are strong social and economic imperatives to address the burden of cognitive decline and dementia on a population level, as well as through targeting high-risk populations, given that the rapid increase in global aging populations.
Yeah. I agree entirely. Music to my ears, what you're saying. So do you want to tell the people who are watching about your paper, your methods and what you found?
Yep, so our study used the PROGRESS trial, which was a landmark blood pressure lowering trial conducted in 1995 to 2001 across 10 countries in Asia, Australasia and Europe. The aim of the present study was to examine the randomized treatment effects and the major and common cardiometabolic, genetic, and also stroke-specific predictors for cognitive decline and dementia, while we incorporate the competing risk of death and also examining the sex differences in these predictors. So over a median of 4 years follow-up in PROGRESS, there were 763 cases of cognitive decline and or dementia, with 1/3 of these cases being women. And these were recorded in nearly 6,000 participants. So we found that active treatment was associated with low odds of cognitive decline and dementia as a composite outcome, with no evidence of sex difference. And in terms of the predictors, higher education and baseline cognitive function measured using the Meaning Mental Status Examination, or MMSE, were associated with lower odds of cognitive decline and dementia, and higher diastolic blood pressure and peripheral arterial disease were strongly associated with higher odds of cognitive decline and dementia. Further, low estimated glomerular filtration rate, or EGFR, which measures kidney function, was also associated with a greater risk of dementia alone. And in terms of sex differences, women had a lower odds of cognitive decline and dementia than men. Low EGFR was more strongly associated with cognitive decline and dementia in women than men, and diabetes was more strongly associated in men than women. Thanks.
Good. Okay, so doing these studies looking at, prospective associations with dementia are difficult. There's lots of methodological challenges. And one of the big challenges is something you mentioned there, it's competing risk. So for people who are maybe less familiar with that concept, do you want to just explain the concept and talk about how you handled that in your analysis?
Yes, so this was a novel part of our analysis. Consider that stroke is associated with increased risk of with premature mortality. Death may preclude the development of cognitive decline and dementia. So for late life conditions like cognitive decline and dementia, death should be taken into consideration as a competing risk so that we can achieve more robust estimates in the association between risk factors and cognitive decline and dementia. So in our study, we applied this using multinomial logistic regression models by defining death with no cognitive decline or dementia by the end of the follow-up as one of the multinomial outcomes. We use these methods since the onset of cognitive decline and dementia can be highly insidious, so traditional time to event models may not be reliable.
Now, the data set you used was from the Progress randomised controlled trial. Progress, I remember, was recruiting when I was a medical student and I did my elective in Australia, so that's not yesterday. Do you think those data are still relevant to contemporary practice, or are we treating cardiovascular risk factors much better now?
Yeah, so Progress was a groundbreaking trial at the time, and the results remain robust and important nowadays. So risk associations, like, for example, the causal effect of smoking on lung cancer, which was known since the 1940s, are not time sensitive and is still very much relevant till now. And the choice of outcome events in Progress is realistic in that it reflects the patient's point of view, and that is important not to just avoid stroke, but also avoid sudden death or myocardial infarction. Progress was conducted across multiple countries, and most patients came from industrialized areas that has good external validity. Also, the specific drugs used in the trial, perindopril and indapamide, continue to be affordable, effective, and commonly prescribed blood pressure lowering treatments until now.
Excellent. So at ESOC, we're going to launch the joint ESO and EAN guidance on post-stroke cognitive impairment. And one of the things we looked at was prevention. And we felt when we looked at the synthesis of all the evidence that there wasn't yet strong enough evidence to make a strong recommendation for blood pressure reduction solely for its cognitive benefits. Now, we didn't have access to your paper when we were creating the guideline. Do you think your paper and the data from Progress should change the recommendations that we make? Or do you think there's still a need for more research?
Yes, so I would say so. So expanding on previous Progress work, which showed that this was only significant for preventing dementia or cognitive decline in people who had a secondary stroke. Our study further demonstrated that after considering death as a competing risk, active blood pressure lowering, particularly combination blood pressure lowering treatments, that is perindopril plus indapamide, showed benefits at lowering the risk of cognitive decline and dementia as a composite outcome. This is important, given that currently we have very limited treatment options for cognitive decline and dementia. Prevention and effect modifications of risk factors remain to be the key in addressing the burden of post-stroke dementia. However, I guess in practice, when treating elderly individuals, the potential cognitive benefits of blood pressure lowering should be evaluated in parallel to their life expectancies and also comorbidities, as well as possible side effects from blood pressure treatments as well. And of course, further prevention trials aimed specifically at lowering the risk of post-stroke dementia are needed to clarify the efficacy in blood pressure reduction, and particularly in more in specific risk strata as well.
Okay, excellent. I've got one final question, just picking up on something you said there. In a sense, we're going to treat hypertension anyway. We're going to treat vascular risk factors anyway. Do you think your findings will really change practice?
So I guess people with previous stroke constitute a very distinct risk profile and are not limited to those with diabetes or hypertension or kidney disease per se. And they're particularly prone to have further stroke within the 5 years follow-up, as well as high risk of cognitive decline or dementia. So these conditions do have a strong tendency to occur together, particularly in people who have had a previous stroke. So I would argue we might say that particular attention is needed for stroke patients stroke survivors actually with comorbidities to monitor and manage their cognitive health after stroke. And there are available treatments for specific comorbidities as well, which may be important in preventing cognitive decline and dementia in these patients, given that there is a paucity in disease-modifying treatments for cognitive decline and dementia. But I guess, however, whether there is a need for more aggressive treatments for individuals with these comorbidities will require clarification still.
Yeah, couldn't agree more. Jess, it's been great talking to you. Thank you.
Great. Thank you, Terry.